Well, um, so Anne asked me to talk about the comorbidities. So just kind of as a disclosure before I get started, I am a pulmonologist. So a lot of what I'm going to be talking about has to do with gastroenterology and infectious diseases, and so I'm not a gastroenterologist. So I may not be able to answer all your questions, but I'll try. Okay. So these are the objectives for the talk. Essentially, I'm just going to review a few of the comorbidities that we see. So the first one I'm going to look at are some of the infectious complications, because I think everybody's had it where, their kids have had a viral illness, and we can kind of go over how we all kind of think about that. We're going to talk real briefly about pulmonary hypertension and supplemental oxygen and the reasons why we do that. We're going to discuss failure to thrive, define it, let you guys know what we're looking at, and how it affects lung development. And then finally, I'm going to go into just tachypnea, dysphagia, reflux, and how it can all kind of affect your kids. After I'm done, Haven will get up and talk about kind of management of these things. So first off, infections. So as we all know, viral infections are very, very common in young children. There's estimates that in kids under 2 years of age, they'll get 10 to 15 viral infections per year. So you're talking one a month at least, sometimes more, and that's on average. So if you do an average, there's going to be kids that get twice that. So very, very common. And that the reason behind that is that when we're young, we're still developing our immune system. So every little kind of thing we come in contact to can cause an illness. A lot of the viral infections that they get have respiratory symptoms, runny nose, cough, things like that. And we all kind of feel that it can definitely lead to an exacerbation of your underlying lung disease. And by exacerbation, I mean the way we kind of think of these diseases is that almost all of them reduce our reserves, our lung reserves. So you or I who don't have an ILD have tremendous reserves in our lungs. However, if you've taken a lot of that away by having a lung disease, any little thing can kind of can make you very sick and need more oxygen and potentially need the hospital. So these are some of the common respiratory viral infections that we'll see. They have different times of the year. They're more prevalent. So it kind of depends on where you're at. Rhinovirus is just the common cold. That's kind of around all the time. And most of these are diagnosed either with just by symptoms. So you'll go see your doctor and they'll say, you've got your runny nose and a cough, and we'll just kind of say, we think you have a viral illness, and that's a good enough. Or there's some testing we can do, some DNA testing, things like that, if we want to be certain. And so treatment, which is kind of frustrating, I think, for a lot of, for our physicians, parents, everybody, is pretty much supportive. We want you guys to, maintain good hydration, make sure you're eating, mostly drinking well. I'm pretty liberal with allowing parents to play with oxygen. So if you think you need another liter during the day and are all right, and your child's okay doing that, and you're all right watching them, then I'm very liberal with it. Adjust the oxygen as you guys see fit. And then occasionally kids do need to be hospitalized for just a viral illness. The oxygen needs or requirements, or they're not eating, is just so much that we need to do that. There are very, very few specific drugs for viral infections. Flu is one of the exceptions. We have good drugs to treat that. And then severe adenoviral infections we can sometimes treat. But the vast majority of the viruses, there's just no medicines for. And so I think this is one of the more important things that I wanted to put out there. You guys do a great job of preventing as many as you can, but it's impossible to completely prevent all viral illnesses. And if you try and that's your goal, it's going to be very difficult for you to make that goal. So it's going to happen. I think it's important for you guys to know that they're going to happen, and that we can help you work your way through them. There are a few things we can do to kind of avoid this. Mostly they're just common sense things. So number one on the list is good hand washing. Most parents carry around a little thing of Purell, and that's useful. That helps. So you want to avoid situations where there's sick people. So if you have a sick family member, it's probably not the right time to go visit. And most people will understand if you say, we just can't come over. There's good hand washing again. Avoid daycare if possible. We do know that certain circumstances and things may not allow you to not have your child in daycare, but if possible, there's a lot of viruses. Next on the list is good hand washing, and then the other things are again common sense. If church daycares, things like that are areas where kids can get viral illnesses. If your kid is already sick, it might not be the best place. And then finally, good hand washing. And then kind of recently, there's this paper that's come out. So previous to this kind of paper, there's this specific preventative medicine specifically for RSV, which is respiratory syncytial virus. It's a specific virus kids get. It causes bronchiolitis. And so if you've had any other children that have had that, this is probably the virus that caused it. We can give, it's essentially immune globulin or an antibody against this specific virus to kids to help prevent disease or to lessen how sick they get with it. It is a monthly shot. It is expensive. Not all insurance companies cover it. There's very specific guidelines for what they'll cover. And to be honest, there's some controversy even within the child physicians whether or not kids with child should receive Synagis. There are people that believe very strongly they should. There's people that believe maybe they shouldn't. And so anyways, so there was a recent paper, the citation's kind of right down here for anybody that wants to look it up, that kind of came out this past year that did show that there was a benefit for Synagis in kids with interstitial lung disease. So it was in Denmark, I think, a European country where they did an entire kind of registry. They have national health care, so they can identify every patient, and showed that if you have an ILD, they were more likely to be hospitalized and be sick, which is really what the insurance companies care most about, which is keeping kids out of the hospital so they don't have to pay for it. So this may help. Yes? What would be the reasons for not giving it? For not giving it? Yeah, so that's... Yeah. So there's those of us who believe that it's too much. It is a monthly shot, and that while it's been shown to work well in things like prematurity, it may not provide a lot of benefit in somebody that has ILD. I do think this paper has kind of reversed that thinking in a lot of ways because it has shown to be beneficial. Yeah.
Shots for the first three. Pardon me. I can speak on that. My daughter's 9, and she had the first 3 years of her life were from Canada, and so fortunately it wasn't a cost for us directly. But they give it for the 6 months roughly that the RSV season is, and I believe strongly that kept her out of the hospital. And then when my second child was diagnosed as well, then I definitely was after them to make sure. But it is hard to get approval depending on where you go to actually get approval for that, because generally they give it to heart kids.
Yeah, it's a heart prematurity, so under like 30 weeks gestation at birth. And it's if you're under 34, if you have school-age children, that's kind of an automatic. And beyond that, it can be difficult to get insurance companies to cover it. But I think this may help a lot of us in getting that for the kids. So. And then again, it's only for kids 2 years and under. So if your child's already older than that, they've probably already had RSV and developed their own immunity to it. All right. So the next kind of big topic to talk about, and I think this is kind of the big bugaboo or scary thing that a lot of parents hear about, is pulmonary hypertension. And so essentially this is just high blood pressure in the lungs is kind of the best way to think about it. So our circulation in our bodies is kind of broken into two parts, or that's kind of how we think about it. They're connected, but it's different. There's the blood that goes to our body, and that's the blood pressure we all think about, normal, of 120 over 70 or wherever normal is at this point. And that's one kind of blood circulation that we have. And then the other one that people don't always kind of think about is the circulation that's needed to go to your lungs to get oxygen so that it can then go back out to the body. much lower pressures. So normal pressures are about 15 to 20, which in the body can be up to 110, 120. So we kind of define pulmonary hypertension as greater than 25 at rest or 30 with exercise. We do screen for these for most of the children who are on oxygen. You screen with an echocardiogram or an ultrasound of the heart where they look for certain signs that can tell us if there's pulmonary hypertension. And then this blood test, which is a BNP, which a lot of us will get as well, that it can be elevated in kids that have pulmonary hypertension. Just to know, echo does simply estimate the pressures, and there are benefits to it. It's obviously it's not a heart catheterization. It's not invasive. It can be done, but it is an estimate. So it's not as good as a cardiac catheterization in finding these things, but I think it's the best we got, and it's pretty good in our kids. Occasionally, we will confirm the diagnosis with a cardiac catheterization, which is where they kind of thread a thin wire into the artery, and they can actually directly measure the pressures. So there's multiple causes of pulmonary hypertension. There's this idiopathic that the definition of idiopathic is we're idiots and we don't know what causes it. In other words, we don't know why it's out there. There's familial causes. There's a gene that's involved. You can get it from having bad left-sided disease, or the part of the heart that pumps out. And there's numerous other causes. Most importantly for our patients is low oxygen saturation. So if you've got chronically low oxygen in the lungs, it can lead to changes in the arteries in the lungs, which can lead to pulmonary hypertension. So I think I kind of went through some of these. So I kind of made these graphs. So this is what everybody wants for their oxygen saturations, I think. I think everybody wants a straight line across 99 and no variation, or 100, or wherever you're at. And I think when most people think about when they're first doing pulse oximetry, this is what they expect to see. What really happens is something like this. And you can do time in days or weeks or months or hours. It doesn't really matter. You're going to get a lot of variation. In normal people, you can get a lot of variation in saturations. And so really what you want to look at is the white line is kind of the average. And we want to keep that average above 93%. So you will have dips below that occasionally, but as long as we kind of feel like the average is good, we feel like you're doing well. So this is kind of what a lot of kids with chILD are like before they're diagnosed, or as they're early kind of in their disease before we get them on oxygen. And you can have times where you're into the good range and times where you're really low. But when we look at it, your average is too low. And so what we're trying to do is to add oxygen, add supplemental oxygen so that we raise the average back up to an acceptable level. And so Leland used to always talk about this with the families, and it's really we're looking at the average. So it's okay to have occasional dips below 93% as long as most of the time you're above it. Yes, there's a question.
Are there any signs that we would be able to recognize if pulmonary hypertension was starting to develop in our kids? Sure.
So yes and no. So a lot of the times it's what we'd call silent, and there aren't a lot of signs that are occurring. However, if we kind of ask the right questions, a lot of times we hear some of the symptoms. So increasing exercise intolerance. So if you're really struggling with exercise more than you had been, that can be a sign. At Texas Children's, we've actually found that syncope or near fainting has been associated with some of the kids that have pulmonary hypertension for other reasons, but no reason why it couldn't happen here. And really, You know, they're all these things like that, the increasing difficulty breathing, they're all kind of non-specific and can be related to your lung disease, which is why most of us feel it's important for any of our kids that are on supplemental oxygen to screen for these, to do testing, to make sure that this isn't going on.
Do you have any recommendations for, we did an echo on my daughter a couple of months ago, just a yearly echo. She's 2.5. She's terrified of anything to do with doctors, and she screamed through most of it, so her results were inconclusive. So what do you recommend we do from there?
Normally I would follow the blood test a little more in that case. So if the blood test looks okay, then I'm fairly reassured. And to be honest, with the next one, I'd consider doing it with some very mild or moderate oral sedation, so that she kind of relaxes and can get it done.
Would you, for a patient who is knee-high, back here,
Okay.
knee-high or LIP, or any of them for that matter, because some are less likely to be hypertensive, from my understanding, how often would you recommend then having a screening for that?
So in my opinion, if you're on supplemental oxygen and or otherwise you don't have a history of pulmonary hypertension or an elevated BNP or anything like that, yearly. Okay. Any other questions on pulmonary hypertension? Okay. So the next big thing to kind of go into is failure to thrive, which affects a great number of the kids with chILD, and is a very important thing to talk about. So really, the way we define it as doctors is that if you're below the 5th percentile, so you guys have all seen the growth charts, and we have the lines, and so if you're below that lowest line, we consider that to be failure to thrive, and that's for everybody. It doesn't matter if you have lung disease or for whatever reason, or a rapid decline in weight to where you're kind of, let's say you were 75th and now you're in a couple of months you're 10th percentile. Well, while you're technically not below the 5th, that's failure to thrive. And it can be due to multiple causes in children. In our kids that we see, it's almost always due to increased caloric needs because they're breathing so hard. They're just using up all their calories to breathe. So I have just a couple of examples. So, sorry. In this example, along here was actually where the failure to thrive is, and this is a patient of mine that has knee high, and it was right about here that I saw him in clinic for the first time and made the diagnosis. And probably more important than that was I had my dietitian see them, which is unbelievably important in the management of failure to thrive. And I have a great dietitian. She's wonderful, and she communicates with families essentially weekly when they first get in via email and phone calls, and has them take weights. And as you can see, kind of over the months, he's now doing well and wouldn't be considered failure to thrive. We mostly accomplished this with increasing the amount of calories he was taking by changing. So normal formula has about 20 calories per ounce, and we upped him to 24 calorie per ounce formula, and that made a big difference. So this is kind of an example of the other kind of failure to thrive. So technically, she doesn't meet failure to thrive because she's still above the 5th percentile. This is a patient of mine that had heart disease, and while not biopsy proven, I believe she has alveolar simplification. But you can see she was 25th or 50th percentile at first, and she's just really leveled off. So I would actually consider this failure to thrive. She is in the care of my same dietitian, and our biggest struggle with her is that we just can't keep up with her calories. So these are the growth charts that you'll see, and this is when we get worried. So why do we get worried about this? And beyond just nobody likes to see a kid not gain weight. It's actually quite important for further lung development and improvement in lung disease. So I think a lot of us talk about it and a lot of the chILD diseases, as kids get bigger, they get better. Not all of them, but a lot of them that kind of happens. And probably one of the big reasons is that you develop more air sacs or alveoli, and you kind of increase the size of your lungs. And so you gain some reserve. So when we were talking about that, our kids have a lot lower reserve. You actually start gaining some reserve, so you do better with it. The most important thing to lung growth is actually linear or height. So the taller you get, the bigger your lungs get, the better you do. Without that, we worry that your lungs are not developing as quickly or as well as they could, and that could lead to some more problems. This is especially important in alveolar simplification. There's a lot of literature out there in BPD and how much better kids get with linear growth or growing taller. And so I can't stress this last point enough, is that maximizing nutrition is extremely important, in that collaboration with from a physician standpoint with a dietitian or a nutritionist is very, very important to help that. I would not, I don't know what I would do without my dietitian. She is great. She helps. She's always willing to see patients, and she stays in great contact, and we've definitely know that we're doing the best we can for them. Yes?
It may be important, depending on where you are, it may be important to really think about that ahead of time before you go in to see the specialist, because I know at my institution I have to get approval, make sure insurance is going to cover the dietary visit. It's a separate visit. We don't have somebody on hand in our clinic. And so if I know ahead of time that somebody that's coming in to see me has growth problems, I can get that approved ahead of time and make sure to make an appointment with a dietitian the same day, save the family a trip. So think about that as you're thinking about lungs and oxygen and all that. But remember, if you want help with the growth, and that's very important, you may need to ask for that ahead of time.
And I probably should have put another bullet point up here, which is that to maximize nutrition, we do occasionally need to do things like G-tubes and overnight feeds and things like that. We don't like to do that, but the reason why we do it is that kids spend 10 to 12 hours a night sleeping, and if you can give them calories during that time, a lot of times they get a lot better on their growth. And so we do try everything we can before that, but and we do recognize the burden on you guys when we recommend that, and it's not something we do lightly, but we're doing it because we want their lungs to grow and do well.
My question for you is, my daughter was born at like the 10th percentile. So if she's at the 25th percentile in height right now, I'm all excited. But I mean, what can I do to get her to grow taller if she's just a shorty like me?
Yeah. So there is definitely genetics involved for sure. So I'm not expecting my child to play professional basketball and dunk. It's not likely in the cards. So we do take that into account. So if both parents are shorter, then that's important. But really, the way we kind of think about things is that linear growth kind of follows weight gain. So if you gain weight, you tend to grow taller as a child, and so that's how we work on it. Any other questions? Okay, so kind of the last topic to discuss is this whole interaction of tachypnea, problems feeding, dysphagia, and reflux. So you guys have heard this throughout the day. Tachypnea is rapid breathing, and it kind of depends on how old you are. If you're an infant, it's actually 60, but for a lot of the young children, it's more than 40 would be kind of the definition of tachypnea. Dysphagia is just simply difficulty swallowing, or painful swallowing was actually what it stands for. But this is aspiration and issues like that. And then GERD stands for gastroesophageal reflux disease, And so essentially that's movement of the gastric fluids up from the stomach into the esophagus, mouth, things like that. So importantly, all these things are interrelated, and that's why I kind of grouped them together. So if you're breathing fast, you're more likely to swallow air, you're more likely to distend your stomach, which makes reflux more likely. If you're refluxing and you have dysphagia, you're more likely to aspirate that fluid into your lungs and cause problems. And so they're all kind of related to each other. And then, like I said, the biggest thing with all this is aspiration, and this is what we want to prevent. So any aspiration can be kind of irritating to the lungs, and if you've already got a lung disease and now you're aspirating on top of it, you can do some damage to the lungs. So this is actually a picture which some of you may recognize and say, well, this kid has an ILD. It's got a lot of the features of that. It's kind of got the gray areas and the thickened septa and the septal thickening and things that if you've seen a lot of CT scans, you'd recognize this. This was actually a child that had an abnormal connection between the esophagus and the trachea called a TEF, or a tracheoesophageal fistula. So she also had Down syndrome. So some of this may be related to the Down syndrome and some simplification, but the vast majority of this is probably due to the aspiration of the gastric contents into her lungs. So it can cause bad disease in and of itself. Unfortunately, aspiration can be very hard for us to diagnose. There isn't really one really good test that's going to catch every kid that aspirates. We do video swallow function studies, and I have one to show you guys. We do upper GIs, we do pH probes or manometry, which I'll show you guys all these different tests. But I guess the punchline to all of them is while each one of them can diagnose aspiration or help us diagnose reflux that may be causing aspiration, none of them are perfect. And so we need to kind of, as clinicians, we kind of take into account all of them and try and help you guys with it. So this is the first kind of slide that I wanted to show you guys, and this is a swallow function study, and this is a still picture of one, and essentially to let you guys know what you're looking at, the child's face is this way, and we're looking on the side. This right here is this is barium that they've swallowed, so that shows up as black on X-rays. This is the esophagus. This is where all the fluid's supposed to be going, and this front part's the trachea. So this is significant aspiration into the trachea. This is what we're looking for. If all swallow function studies were this clear and good, it would be great, and we wouldn't have to worry about it. Unfortunately, most of the time we don't see it this well. We see tracheal penetration or pooling, and those can be what's difficult to know what to do with. So this is the video. Let me play it here for you guys. So before I play it, let me just tell you what you're going to see. So again, the same thing, faces this way. And what you're going to see is you're going to see some of the barium coming down, and it's going to go at first well into the esophagus, but you're going to notice that some of it kind of pools in the back of the throat and eventually kind of spills over and kind of sits right at the airway. It doesn't show frank aspiration, but this is essentially what we see a fair number of the time. And then we have to make decisions based on this data, what to do. So you'll see just kind of a little lick of black right there. If I can get this to work. So there's the barium, and then you can start to see it move forward. And actually when it pauses, you'll see, so that's the beginning of it. The video is actually a little bit longer. For whatever reason, it wouldn't play properly on the system. There actually is some aspiration later. Oops. And so this is just a still picture of the next test that we kind of talk about, the upper GI. And so essentially what we're looking at is similar. They put that same barium essentially down into the esophagus, and then they take pictures afterwards. And so this is, you'll just have to trust me on this one, but this is after it's already gone into the stomach, and then they see it coming right back up. And that can be one way that we diagnose reflux. The two other ways, oops. Okay. So the two other ways that we diagnose it, this over here is a pH probe. So I don't know how well it projects, but there's a small tube that's going into the nose and down into the esophagus. And essentially it's something that can measure pH. And so our stomach is acid, so it's got a low pH. And as it comes up, it can kind of, the probe can sense if the pH goes down, and it can tell you if you're refluxing. You can't really be on medicines for this because medicines, all the reflux medicines lower or raise they take away the acid essentially, so your pH is normal, so it can't really tell that. This over here is actually kind of a newer thing that we've been doing that the gastroenterologist is called manometry, and essentially it just measures the potential difference, or it measures a change in the cells when fluid's there in the esophagus. And so this can measure non-acidic reflux, and that's the advantage to it. So you can stay on medicines when you do this one. This is probably a little bit better of a test, and we're starting to do more and more of that. How do they test for what? Oh, it's the same thing. It's a tube, a probe that goes. It's just a slightly different probe. So anyways, I was told you should kind of end on a fun picture. This is my son. The first time that I decided to feed him spaghetti. So anyway, so I guess the punchline to the reflux and GERD and aspiration is that it can be difficult for us to diagnose. If we do diagnose it, treatment is really kind of it's not fun. It's holding feeds and really only feeding via G-tube, which can lead to problems that we'll talk about in a moment. So it can be difficult for us to diagnose. But the importance of it is that if we do diagnose it, especially in kids with chILD, we really want to make sure we're not doing further damage to the lungs. So, all right, and then yes.
This one, right here in front.
Oh, yes.
How many of your kids do you see with GERD, correlations, GERD with, say, an ILD?
Yeah.
And then on top of that, how many with GERD have a delayed gastric emptying?
Great questions. I don't have percentages that I can give you off the top of my head. I'd say a significant number have reflux. Gastric emptying, I always have a hard time with. I think that a lot of kids that kind of have feeding issues can have some delayed gastric emptying, and in general, I end up sending them to the gastroenterologists to kind of help me out with that. So, I mean, I don't know. What do you think, Leland? A quarter of the kids or so have reflux? Yeah.
So I'm not sure if this question will go into the next session or if it's appropriate here or not. It's two questions. When you're going to have a G-tube and fundoplication, my daughter had hers done, say, 7 years ago. So it's my understanding now that there's a way in which to do it that they can still vomit if need be, because she doesn't need her G-tube anymore. It's since closed after 3 years of using it. But when she gets sick and needs to throw up, she can't, and the retching and the retching and the retching, she turns purple with no relief.
Yeah, and that can be a problem with the Nissen part of it. For whatever reason, kids that have Nissens do seem to maybe have some retching and issues with that, and it's a fine balance with the Nissen, because the whole purpose behind it is to stop the reflux that's causing the issue in the first place. So it has to be tight enough to where it stops the reflux.
Is there anything you can do about it after the fact, though?
You can undo a Nissen if it's not an issue anymore. Mm-hmm.
Oh, well, that would be exciting news for her, although she doesn't.
It requires a surgery. I mean, it's another surgical procedure, but they can unwrap it.
Okay. The other question I'd have quickly about tachypnea. How many kids are you seeing that have extreme pectus excavatum from the breathing? My daughter was 170 breaths a minute at 6 weeks old, so her rib cage was extremely pliable, and her chest is almost completely folded in. And so how does that affect their breathing long term?
So that's a great question. And again, the answer is probably I can't give you a percentage because I don't know it. But it's a significant percentage of kids, and it's exactly what you talked about. We think it has to do with the fact that they're breathing so hard that it affects the development of the chest. Most kids that don't have lung disease, their pectus may cause mild restriction of their breathing, but it's not much generally.
Yeah, because hers, you could probably set a grapefruit in the hole.
Yeah, even when it's to that degree, it does change the mechanics of how you breathe. So it can have some effects, but we almost never see it to where it's causing severe issues in children without lung disease.
Because I was told that adds to the stomach being distained quite a bit because the pressure pushes down.
It can affect the way other organs are set up, including your stomach, because we're all kind of meant to be set up with the arrangement that we are, and so it can put increased pressure on the stomach, and that could lead to more likely reflux and things like that.
And so then the opposite, because I have 2 children affected,
Mm-hmm.
my son is barrel-chested, quite extremely so. So can you tell me the difference between why that would happen? And I mean, I know why it caved in, but I don't understand why my son is so barrel-chested.
Normally that has to do with air trapping. So generally kids that get barrel-chested are the population we think about as the cystic fibrosis kids. And most barrel chesting has to do with the fact that for whatever reason their airways aren't allowing them to kind of breathe out all the air that they need to. So some of it's getting trapped in the lungs, and that's expanding the chest beyond where it should be.